Welcome to newborn screening program updates from Bloodspot collection program and also our hearing screening program. Sarah, can you see the slides?
Yes, we can see the slides.
Excellent. Okay. So the way we're going to do this morning is we are going to talk about Bloodspot collection first. We will have time at the end for questions. You can put your questions into the chat anytime. We'll also try to unmute participants at the end of the specific training for questions as well. And then after that, we'll move on to hearing screening. So again, welcome and thank you guys for joining us. So here are our training objectives. Really, why are we doing blood spot screening? Why is it important? What types of disorders are we screening for? What can we do prior to collection to get really good blood flow, to get a good blood spot specimen collection? And then what does a good specimen look like? And what does a specimen look like that's not going to be accepted by the lab, an unsatisfactory specimen? So what is blood spot screening? Well, it's our state public health program, and the Oregon State Public Health Lab does the screening for New Mexico specimens. And really our goal is to identify babies who have these disorders that's on our screening panel really before they develop any type of symptoms. Babies can be little ticking time bombs. They tend to look and act healthy at birth, so you can't look at a baby and know that they have one of these conditions that we're screening for. The disorders aren't common. They do have treatments. So currently we're screening for 45 different disorders on our panel, and about 20 of these disorders can kill or severely harm an infant if it's not identified and treated in the first 2 weeks of life. New Mexico is a two-screen state, so if we only screen once, then we could miss disorders. So it may be normal on the first screen and then abnormal on the second screen. So if you have families who only want to do one screen, it is important to let them know, hey, here's why we do two screens. These are some of the types of disorders that we screen for. We follow a national panel. So when the national panel adds a new disorder, then Oregon has an advisory board that meets to determine if it's going to be added to our panel, and then New Mexico follows suit as well. So we've added a couple of conditions in the past couple of years, and we'll be adding more in the near future. It does take us 2 or 3 years to actually add a condition to the panel. We have to get the equipment, validate the equipment, do all the training and upgrades needed. So it's not a simple process, but a really important one. So in New Mexico, we screen about 20,000 babies a year, and more than 50 are diagnosed and treated for one of the conditions that we screen for on the panel. Again, we're only doing the screening part, so babies still need confirmatory testing, diagnosis by the primary care provider, and then treatment depending on what the disorder is. And I know for a lot of people, this is a point of care test, but it's a really important point of care test, and it can be life changing for families. So what do we call newborn blood spot screening? Well, we call it newborn blood spot screening. What we're trying to avoid and we're trying to change is kind of the older way of calling it PKU test or PKU screening. And of course, that's where we started back in the 1960s. However, because we screen for 45 different conditions on the panel, we don't want to imply to families that we're only screening for one condition. And if you call it the PKU test, that's exactly what we're doing. We also, if their baby does screen positive and they've only heard it called PKU test or PKU screen, what are they going to Google? PKU. And then we're going to have to undo Google damage and really explain, nope, this is actually the condition that baby screened positive for. So I know we've just met and I'm asking you to make a change already, but this is really important that we call it newborn blood spot screening. Newborn metabolic screening is okay as well. It's also really important to educate families about the screening prior to collection and let them know to ask the primary care provider for results of both the first and second screen. So here's an example of how blood spot screening can save a life. This is little baby Maisie. She was born in Oregon last summer, parents' third child, two healthy kids at home. She was a big baby, weighed almost 10 pounds. Mom was aware of newborn screening. She'd had it for her first two kids, but really didn't have any concerns. And yet, Maisie screened positive for MCAD. And this is a condition where fatty acids can't be broken down and turned into energy. And this leads to low energy, low blood sugar. It can lead to liver damage, coma, and death. So luckily, Maisie was identified with this within her first blood spot screening. And we're going to talk a little bit about more about her later on. So we have goals for specimen collection. A lot of them revolve around our timing because, again, we want to identify these babies as quickly as possible. So for our first specimen, we want that collected as soon as possible after 24 hours, but before 48 hours of age. And then the second screening is usually done between 10 and 14 days, usually at the follow-up visit with the primary care provider. We do want to receive specimens to the state lab within 48 hours of collection. And we want to minimize unsatisfactory specimens. So our goal is to reduce the unsatisfactory rate to less than 3% statewide. And I will show you some data here in a minute on the next slide. But anytime we have an unsatisfactory specimen, it's going to cause a delay. So we're going to have to redo the screening. So our screening results are delayed, confirmatory testing's delayed, diagnosis is delayed, and treatment is delayed. And days can mean the difference between having significant disability and not having disability. And for some of our time critical disorders, it can be the difference between life and demise. So our goal is to have our first screen results to the primary care provider as soon as possible, but no later than 7 days of life. So this is a snapshot of last year for New Mexico. And we send out a monthly QA report to all first submitting hospitals, community birth providers. So if we look on the left-hand side, the unsatisfactory specimen rate for New Mexico for 2023 for first specimens was 11.3%. And if you remember from the previous slide, we want to get that under 3%. You can see some of the other goals and benchmarks that we're trying to meet. But we're really this training's focused on how to collect an acceptable specimen so we can get that unsatisfactory rate way back down under 3%. So back to Maisie. So how did all our goals work for her? Well, that first specimen was collected at 24 hours plus 3 minutes of life, which is great. The specimen was received to our lab 32 hours after collection, so that's meeting our goal. Screening results came back on day 5 of life, which is exactly what we want to see for a time critical disorder. So what happens at that point is our follow-up coordinators, Christy and Sarah, would reach out to the primary care provider that you guys have listed on the specimen card, and then we're going to coordinate care between the primary care provider and consultants. So the family was notified by the primary care provider that day of their screening results. Confirmatory testing was scheduled. And this is Maisie. This picture is a few months later, and she is healthy and doing great. But it's really important to think about, well, what would have happened if some of these goals weren't met? If we didn't collect that specimen in 24 to 48 hours, if we didn't receive it to the lab within 48 hours of collection, this might be a totally different ending to this story. So again, this is what it looks like kind of from the first collection through to the end of the second collection. So we have birth of the baby, we're collecting that first specimen between day 1 and day 2, we're getting it to the lab, we're doing our testing. It takes about 48 hours of turnaround time minimum between when we receive the specimen and when we have results. So again, we're getting those results out between day 5 and day 7, and then we're doing it all again. So between day 10 and day 14, we're doing that second collection collection, getting it to the lab in a timely manner, doing the screening, and we want results out between day 14 and day 18 for a second specimen. When we look at NICU specimen collection, just a little bit different. So babies in the NICU receive 3 screens. So one at 24 to 48 hours, one at 10 to 14 days, and then one around 28 days of age. If a baby's receiving a red blood cell transfusion, we want to collect that specimen before the transfusion. So if that first specimen was collected before 24 hours because of the transfusion, then we do want to collect an additional specimen at 48 to 72 hours of age so we can make sure we have accurate results. So again, a first specimen should always be collected between 24 and 48 hours unless there's circumstances like a transfusion, like on the previous slide. A specimen should be collected before baby's discharge from the birth facility, and ideally that's not until baby is at least 24 hours of age. I mean, we still want it collected before they leave, but I would try to get them to stay at least until 24 hours so we can have accurate results. And then if a baby's going to be transferred to another facility prior to 24 hours of age, it's going to become the responsibility of the receiving hospital to collect that specimen when baby is 24 to 48 hours of age. So it's really important just to communicate to the receiving hospital whether the specimen has or has not been collected, kind of depending on how old baby is when the transfer occurs. So anytime we have an unsatisfactory first specimen, we're reaching out to providers, to Carla, and asking for a repeat collection as soon as possible. So we don't want that baby to wait until that 2-week appointment with their primary care provider and then do the repeat collection. If we have an unsatisfactory first specimen, we want to get results as quickly as possible. So that does mean bringing babies in, usually at a time they're not going to be seen by a provider, but we want that repeat collection done as quickly as possible. Again, so we can get the results and go from there. If we need to do confirmatory testing, if something screens positive, we really want to do that as quickly as we can. And then sometimes we're just reaching out because we need another screen, an additional screening, or an early second screen, kind of depending on what has been positive on the first screen. So the second specimen card really needs to be at the location wherever the second collection is going to take place. So if it's at the primary care clinic, the parents can bring the card to that first visit and the clinic can store it on site. If it's going to be a hospital lab or an outpatient lab, either the hospital can store it if we know for sure they're coming back there, or the parent can bring it to that appointment. It is important to let parents know that the card really should not be sitting in the bottom of a diaper bag for 2 weeks. It is delicate. The fibers of the filter paper can become compressed, and it makes the blood a lot harder to saturate through to the other side of the card. So if you're sending parents home with the collection card, please let them know to really take good care of it, not to lose it. Really should be stored on its edge, not laid flat, because again, we don't want anything to be set on top of it and damage the filter paper. It's also important to send families home with the screening pamphlet so they can kind of review it and remember that they had a screening done in the hospital and let them know that another screening is going to take place. So switching gears, let's talk about the collection itself. So what do we need? Everything here, this shouldn't really be new for anybody. We want to make sure we have the correct size puncture device. So it is based on gestational age and birth weight. So make sure we're using the correct one. First order of business is to always check the expiration date of the card. They do expire. They're good for 5 years, and then the quality is no longer guaranteed. So double check before you start filling it out. And then make sure you're using the correct card. So for a first specimen, use the first card. Second specimen, second card. Third specimen, if it's a NICU baby, use the third card. And then we ask that you fill in everything that we're asking for on the demographic section. We do not have access to any type of EHR system. So all of the information that we have about the baby is what you are writing on the card. So it needs to be completely filled out. And it's really good to have in your work process a way for another person to double check that everything's filled out. If there's pieces missing, we're going to be reaching out to you to ask you those questions, and that can delay screening, which is not what we want to have happen. Make sure you put in the primary care provider or clinic that the family's going to be following up with, and we'd like the full clinic name and then some sort of identifier as well, a phone number, an address. We don't want to use acronyms or short forms, especially when there are multiple locations of the clinics and they all have the same name. Um, and please, when you're putting in the weight, we would love that in grams, not pounds and ounces. So our submitter cards have a code on them, and that says this is your facility's card and your department's card. So if you have a NICU, they are going to have a separate code on their card. So don't switch back and forth with cards, or it really affects. If we need to do outreach, we might reach out to the wrong department. It also messes up with our QA data, which we don't want to have happen. So I mentioned that the cards are delicate. So again, if you're storing unused cards, they need to be stored on their edge. So in a filing cabinet or an accordion folder like you see in the slide. We just want to make sure nothing gets set on top of them. The other important part is to not touch the filter paper with your fingers at all. Again, we don't want to damage the fibers of the filter paper, and we also don't want any extraneous DNA on there from you. So what are we going to do to get the biggest, fattest drops of blood from this baby? Well, we need to dress baby pretty warmly. Okay, so you can see in the picture, we got baby all swaddled. We got the hat on there, mitts, boots, everything. Um, I find that in the hospital setting, rooms are either really, really warm or really, really cold. So dress that baby up. Um, Parents can help if you are doing the collection in the room with the family. They can be massaging baby's legs. So just poke that one leg out of there from that swaddle. And really, we're trying to push the blood from the thigh down towards the toes. Having baby upright is also helpful. Just allows gravity to kind of help get that blood to stay in the bottom of the foot. We do recommend a heel warmer or a wet warm washcloth is also fine. Some facilities will use oral sucrose for pain control that can be given 1 or 2 minutes prior to the collection. The other things that help with pain control are swaddling, having baby upright, doing that massage, breastfeeding during specimen collection if breastfeeding's going well, if parents have already introduced a pacifier, non-nutritive sucking also can help. What we don't recommend is any sort of topical cream that is like an anesthetic, because that can interfere with our testing. The other thing that's important is to let parents know that it could take more than one heel stick to collect the specimen. Typically not, but it's great to just prepare parents, give them that anticipatory guidance. And that way, if that's the case, if baby just completely dries up after circle number 2, well, you've already told them this is a possibility. Babies just aren't great peripheral bleeders, and some are better than others. But giving them that information ahead of time will just keep their anxiety level down. That'll keep baby's anxiety level down. That'll keep your anxiety level down. And if you get it collected in one heel stick, which is typical, then they're just going to think you're some kind of superhero, which of course you are. One thing that we ask is that you not use any sort of transfer device to get the blood from the heel to the filter paper. It really scratches and tears the paper and causes uneven saturation. There tends to be a whole bunch of blood on the filter paper to the point that it's unusable. So it scratches, it tears, it can cause the filter paper to kind of bubble up. Um, and warp. And then it can also break down red blood cells, and that could lead to false negative or false positive results, which we don't want to see. So when we're looking at our preferred site for collection, really this has not changed over time. It is either side of the base of the heel where you see those hatched marks going across in the slide. We don't want to do the middle of the foot. We don't do fingers. We don't do toes. We don't do earlobes. So we're going to put our heel warmer on and read your manufacturer's directions because some of them are on for 90 seconds, some of them are on for 3 minutes. So follow the guidelines from the specific heel warmer that you have. Now, I don't love this picture in the top right corner because I would have baby all swaddled and bundled up. Even with the heel warmer on, I would just swaddle them back into the blanket until the time has elapsed. And then just poke that one foot out there, right? And then you're only dealing with one foot, and you've got two arms and one leg contained in that swaddle. So we're going to cleanse the site with alcohol and we're going to let it air dry. Um, you need to follow the directions on the puncture device as to how to place it against the foot. If it doesn't come with any specific directions or arrows, the recommendation is to go across the heel print. So perpendicular to the heel print, not parallel, so not following the lines of the heel print. Easiest way to explain that is if you look at your finger and the circles of your finger, the whorls of your fingerprint, you would want to go across your fingerprint, not parallel to them. The reason for that is a bigger drop of blood can collect because it's being held by the ridges of that heel print. So it's usually a bit of an angle. And you're going to apply gentle pressure before you dispense the device. We're not pushing super, super hard. We don't want to hit nerves. We don't want to hit bone. We just want to hit that rich blood bed that's in there. So we're going to puncture the site. We're going to wipe away that first drop of blood because it is going to be contaminated with the alcohol, with whatever lotions parents have applied to baby. Um, this is where, when I do trainings, people say this part is a little bit different than what they've been taught in the past. We can only put one drop of blood onto each circle on the filter paper. So we need to make sure that it's a big one. And the way we do that is we really stop and take our time during this part. So we're going to apply and release pressure around the heel to promote that big drop of blood to form. So you can see in the slide, this person is holding the heel. The hand is pretty far back from the puncture site. So again, they would just be gentle squeezing and release, gentle squeezing and release, not letting go of the foot. But sometimes what happens is we're squeezing the foot the whole time. And then we've essentially cut off the blood supply to the foot. So we want to apply and release pressure until we get that big drop of blood to form, and then we're going to put it onto the first circle of the card. And then we're going to do the same thing. So we're going to apply and release pressure on the foot, get a big drop of blood to form. That's going to go into circle number 2. We're going to do the same thing for all 5 circles, one drop of blood into each circle. And then you're going to ask yourself in real time, while baby is still there bleeding, 2 questions. Are the circles completely filled? And is there good saturation through to the other side of the card? So if you say yes, because it looks something like this, then you're ready to dry the specimen and move on. However, if you say no, because it looks like one of these, so In the top example, you can see there's blood on the front of the card, but you can see on the back of the card, so the 5 circles underneath, areas where the blood did not saturate or soak through. Or does it look like the bottom example where you tried your best, but those blood drops are pretty small and maybe filled a third of each of the circles instead of filling the whole thing with one drop? So if it's either one of these situations, then what I recommend is adding 2 or 3 extra drops of blood outside of the circles. So we do not want to put more blood onto a circle where you've already applied blood. That's going to create layering and uneven saturation. The lab will not accept that. So if you're going to give us an extra 2 or 3 drops, it needs to be just somewhere else on the filter paper. Um, so it can be over the numbers and the words as you see in this example. And these are basically your insurance drops. You're giving the lab more blood to work with, so it's less likely to be determined to be unsatisfactory. So 2 or 3 drops outside of the circles anywhere on the filter paper. Our gold standard is still 1 large drop of blood into each circle and then we're done, but this is giving you a backup plan or a plan B. Now, sometimes when I say add 2 or 3 extra drops outside of the circles, people think, well, if 2 or 3 is good, then more must be better. And that's not the case. So this is what I call the leopard print. The lab doesn't like this. The smaller the drop of blood, the less it saturates through to the other side of the card. So it's much more likely to be determined to be unsatisfactory by the lab. So kind of a recap. So you can fill from either side of the card, but you only fill from one side and you stick with what you started with. So if you started filling from the front of the card, you fill all the circles from the front of the card. If you started filling from the back of the card, you fill them all from the back of the card and only fill from one side. We do see specimens that come in where people have filled on the front and the back of the card. That specimen is going to be determined to be unsatisfactory. And the reason for that is the lab needs to reliably be able to say that when they punch out a disc of blood to be screened, it has to be the same amount of blood in each disc. So if you're layering drops on top of one another, then that's going to be too much blood. And if your blood drop didn't saturate through to the other side of the card, that's not going to be enough blood. So it's kind of like Goldilocks and the Three Bears. It can't be too much, it can't be too little. It has to be just right. And just right is 1 large drop of blood evenly saturated through to the back of the card. So again, we're not going to put blood drops on top of each other. We're not going to let them connect. This is layering, creates uneven saturation. The lab will not accept that. Again, you can put 2 or 3 extra drops of blood outside of the circles if you need to. And then if the blood flow is slow, like we already talked about, baby dries up after the first couple of circles, then you're going to restick the heel in a different location. It can be the other side of the same foot or the other foot altogether. So how much blood do we need? So for a first specimen, we need enough for at least 10 punches, and you can see an example of what the punches look like. Um, and that's the minimum that we need. So we need enough for at least 10 punches plus more if we need to do any type of repeat or additional screening. And it's impossible to know whether we're going to need that, which is why we want those 5 circles filled with 1 large drop of blood in each circle. Second specimens, we need enough blood for at least 7 punches, again, plus more if we need to do repeat or additional screening. And each punch is 3.2 millimeters in diameter, and that's a picture of our punching machine. Okay, so after collection, so we need to air dry specimens. They need to lay flat, so horizontal for 3 to 4 hours at room temperature. And that's all they need. So no direct sunlight, no heat, no fans, no microwave. We don't want to hang them vertically. That will prevent the red blood cells from migrating to the other side of the card. So it creates uneven saturation. Um, we don't want to store them or ship them in plastic bags. We don't want to put that protector cover on until the specimen is completely dry. Um, and we don't want to fold the card at any point in the process, not before collection, during collection, or after collection. Cards need to remain unfolded, and we don't need staples, paper clips, tape. We don't need anything attached to the card. You don't need to send us additional labels with the medical record number on there. We don't use them, and it just creates extra work for our staff when we're opening up specimens. So after they are dry, that's when you put the protective cover over the circles. And again, this is a good spot to double check that everything is filled out in the demographics field. It is important to create a packing list of specimens and to keep a log of specimens that you've sent to the lab. You can put multiple specimens into the same envelope. That's certainly fine. And then it's really, really important that you send them the same day as quickly as possible. I know New Mexico for first specimens typically uses FedEx. So make sure we're not batching specimens. And batching means where you're collecting, days worth of specimens and then sending them out. Specimens should go out really as soon as they are dry. So you should be sending stuff by FedEx daily. And our lab, we are open 6 days a week. We're not open on Sundays. We're not open on holidays, but otherwise we are there processing specimens. So again, you send them to us as quickly as possible so we can turn around with screening results, identify babies that need further care as quickly as possible. So what does an acceptable specimen look like? Well, the circles are completely filled, 1 drop of blood in each circle, and it looks the same on both sides of the filter paper. Um, there's even saturation, so there's no areas of light, no areas of dark. It's really hard to tell by this specimen which side it was collected on. This is an example of uneven saturation. So you can see the front of the card. Well, yep, there's blood in there, but look at the back of the card. You can see those areas of light, those areas of dark, and there's areas where there's just no blood saturation at all. So what happened here? Well, if you're using a transfer device, that can create uneven saturation. Multiple drops applied to the same circle can create uneven saturation. If that filter paper had gotten damaged prior to collection, that can affect saturation, or if the cards are hung to dry rather than being laid flat. In this specific example, multiple drops were applied to each circle. So that's what created the uneven saturation. Another example of uneven saturation, again, this is layering. There's multiple drops of blood applied on top of each other. And again, the lab needs to be able to say they're punching out the same amount of blood each time they're punching out a circle. So it cannot have layered blood on there at all. One more example of uneven saturation. Again, this is layering of drops. If you look at that bottom left circle, you can count about 8 drops of blood that were applied there. And then this is not enough blood. Remember, we need enough blood to do multiple punches. With this specimen, we might get 1, maybe 2 punches if we were lucky. So again, if this is what you had, you would give us 2 or 3 extra drops of blood outside of the circles. And this is an example of what can happen if we're using some sort of transfer device. You can see down the left, there's a giant tear in the paper. The lab's not going to be able to use this. And then this is what contamination looks like. So if we don't let the alcohol dry, we don't wipe away that first drop of blood. If we're really squeezing right at the puncture site, rather than having our hand further back, that can push tissue fluid into the specimen, which later separates, and you get this sort of ring around the blood spot. And transfer devices can also separate blood components. Okay, So now this is your job. You now work at the Oregon State Public Health Lab. You're a microbiologist. So this is a specimen that you received. So you can put your answer in the chat and Sarah will read it out. But what would our concern be with this specimen? So top 5 circles are the front of the card, bottom 5 circles are the back of the card. What is our concern here? Any ideas?
I've got 3 people saying layering.
Mm-hmm. Yep, that's great. Yes, you can see looking at the back of the card, you can count the number of drops that somebody put into that circle. So yes, that is layering, which creates uneven saturation. The lab is not going to accept that. So yep, there's our answer. Okay, how about this one? What's our concern with this specimen? Anyone have an idea?
I've got one person saying maybe a transfer device.
That's definitely possible. Um, there's definitely more than one drop applied to each circle, right? And you can kind of see the outlines of the circles. There's not good saturation. The other thing that's interesting about this specimen is it looks like blood was applied to both sides of the card, which again is going to create that uneven saturation. So yes, thank you. All right, what about this one? What is our concern here?
Is there too much milking or contamination?
Yeah, so that fourth and fifth circle on the right, um, they have serum rings, it looks like. So again, that can be from milking the site, that can be from using a transfer device, and there's also multiple drops applied to each circle as well. Um, what do you guys think about this one? This one's a little bit tricky. We haven't talked about this, and this is the only time I've seen this happen. Um, where you see kind of that lighter area there.
Was
All
it
right, well,
dry? Was it dried on an edge that was not flat or
that's a
transfer?
really good
Yeah.
guess. So there's definitely multiple drops being applied to each circle. We can see that. But what happened here is somebody put the label, the patient label on top of the blood spot. So when we peeled that label off, we peeled off the blood. So again, that will happen with the protective cover. If you put it on too soon before the specimen's completely dry, we're going to peel off the blood when we open it. All right, a couple more. I'm going to kind of give you some hints here. This is kind of what we've been seeing. So we've got multiple drops of blood applied to each circle. Kind of the same thing here. And again, the smaller the drops, the less they saturate through to the back of the card. Um, all right, how about this one? What's our concern here? We should have everybody able to answer this one. This one is a pretty obvious one, and it's amazing that someone sent that to us.
Not enough blood.
Yes, not nearly enough blood. But again, the reason I use this slide is because it's a really good example of how the smaller the drop of blood, the less it saturates through to the back of the card. Okay, last one. What is our concern with this one?
Contamination,
Yep.
or did it get wet?
Yes, it did get wet. It got wet with water in transit. Super unfortunate because it looked pretty decent otherwise. Um, So again, what are we looking for? So we're looking for 1 drop of blood in each circle that fills the circle. If it doesn't fill the circle or the saturation doesn't look great, give us 2 or 3 extra drops outside of the circles. Don't go back and reapply more blood to the same circle. The lab is not going to accept that. But 1 drop of blood in each circle and really even saturation through to the other side of the card. A couple more slides and then we're going to take questions. So sometimes families are concerned with what the lab is doing with unused blood spots. And really the short answer is nothing. So they sit in our lab for 18 months, then they're securely destroyed by our medical waste company. So we may use an unused blood spot for internal quality checks to make sure our equipment's working the way it's supposed to. The only time specimens will be released by the lab is if there's a court order. If the parents want it back, they can fill out a form that has to be notarized, and we will send the specimen back, assuming that we still have it. And then if something catastrophic happened to our lab equipment and we couldn't perform newborn blood spot screening, then we would need to send them probably up to Washington State to have them done for us. But that hasn't happened to us, and hopefully it won't. So the specimens themselves we hold on to for 18 months. The results we hold on to, Sarah, correct me if I'm wrong, it's 5 or 6 years. So that means if you're in a primary care clinic and you have an 18-year-old who wants to know their hemoglobin status from the newborn blood spot screening, we're not going to have that. They're going to have that test redone because we don't hold on to results that long. And a lot of students who are going on to college and want to play sports have to have that result. So they will need to have that test done again. So if families want more information, if they want to know what are the 45 different conditions that we screen for in New Mexico, this is a really good website. It talks about all the conditions that we screen for both in Oregon and New Mexico, information about each disorder. They can compare with every state in the US if they want to, and it talks about the newborn screening process. If you want additional information, New Mexico has a really good newborn screening website. It has the practitioner's manual on there, how to order specimen kits, program updates. And then if you're looking for online results, if you don't want to wait for things to be mailed to you, then you can access our web portal on the Oregon newborn screening website. And there's information on how to get set up on there as well. Um, we follow the CLSI guidelines for specimen collection. So that is their website. And they also have a really good video, and that's the second link there. It doesn't cost anything to view the video, but you do have to create a login. And it really just gives a great example of blood spot collection. And then if you need help or contacts, Carla and Teresa are your contacts. If you have questions about how to collect a specimen, or if you need to reach out to them because you have a family who's declined screening, they'll help you through the exemption form process as well. Okay, and that is the end of my slideshow. I'm going to stop sharing my screen. Um, do we have any questions in the chat?
There was a question earlier about when you're filling out the demographics, do you want the family's physical or mailing address? And I responded in the chat that we want the physical address. In case last resort, we need to track a baby down, we need to know where to go, especially if they're not answering their phone. And then there was another question regarding, do you apply blood to the front or back? Which Laura answered from the lab as well as you did in your next section of your presentation,
Oh,
saying
great.
either one's fine as long as you stick to one side.
Right. Yeah, so it's whatever is easier for you. Like some people like to fill from the back of the card because they can see the blood coming through um, the front of the card and they can get an idea of how well it's filling the circle. I find that a little bit harder. But it's whatever you're the most comfortable with. But yeah, you got to stick with whatever you started with. So if you started filling from the front, you fill them all from the front. If you started filling from the back, you fill them all from the back, and you don't want to fill both sides. Um, I've also, I think, unmuted participants. So if you want to unmute yourself and ask a question, you are also welcome to do that.
Can you share the link for the collection video again?
Yes, I'm going to send you guys a copy of the slides. So it will be on there.
We do have a results portal for anyone to use. It's called SRV, Secure Remote Viewer. We do have a sign up form you need to fill out that's available on our website. Um, and you just fill that out, turn it into us, and you'll get access to look up any baby born within your state.
Mm.
If you don't have the pediatrician's information, like it's an adoption or a surrogacy, if whoever is filling out that card really can't get the information for who the pediatrician will be, then I guess you leave it blank or you write unknown. We always result out to the birth facility, and that would be the first place we would call if we need to try to track down, where baby went.
Right. And it's important that you do, as much as possible, you put something in there, even if they don't know their provider, but we at least know the clinic. If we're trying to call out a time critical result, we need to know who the baby's provider is, or at least the clinic name, so we can track down a provider to say, hey, this baby's in your care, and this is what the screening results were, and we do need to work quickly. Um, so it is important for parents, and maybe it's something you talk to them at the very beginning. While they're in labor, do you have your primary care provider picked out? We really need you to pick one, or at least the clinic, before we do this screening at 24 hours, so we have an idea of where to send results.
We have a couple other questions. Do you have tactics of getting large amounts of blood drops?
Yes. So I would go back to the slide on all the pre-collection tips. So dressing baby warmly, having baby upright, doing the massage of the leg, using the heel warmer. And then once you've punctured the site, you've wiped away that first drop of blood, spending the time to apply and release pressure to get that big drop to form. What tends to happen is as soon as we see blood, we're trying to put it on the card as quickly as possible rather than waiting and kind of applying and releasing pressure and getting that really big drop of blood to form. So part of it is patience. The other thing I guess that I've seen that people have told me they've had success with is actually using two heel warmers, one on the calf and then one on the heel, and then leaving the one on the calf on during the collection. Um, so that's something you'd have to talk with, your nurse manager about and see if that's okay. That's going to be certainly an extra cost. But I have had people say they've had good luck with that. But really, I think it's about making sure baby's nice and warm, good positioning, and then after that puncture, taking the time to get that big drop of blood to form. And I know some babies are really good bleeders, and some babies really aren't. So again, you have that option of giving us a 2 or 3 extra drops outside of the circles if you weren't able to fill the circles with 1 drop of blood in each circle. Great questions, you guys.
Can you go over how to dry a specimen?
Yes. So specimens need to be laid flat to dry. So we don't want to hang them. We don't want the blood to touch a counter or any surface. So there are drying racks that you can buy, that basically you just kind of slide them into the slots and they'll dry horizontally. Or you could get something from like Office Depot that just has horizontal slots like for different paper. You could use that, or they can dry just on a clean counter. We want to make sure that they're completely dry before you put the protective cover on, and then not exposing them to light, any sort of heat source or fan source. They're introverts. They really just want to be left alone to dry. They don't need any sort of intervention. Great question. And I see Sunday Law's comment that warm water in a glove also works great to warm the foot and calf. Yep. Yep, that is definitely a possibility. We do want to make sure that the water is not too warm. So it needs to just be warm water, not hot water. I believe it can't be higher than like 106 degrees Fahrenheit. That comes to mind. Any other questions that we missed, Sarah, or if anyone wants to unmute themselves? Oh, yes. Thank you, Teresa. Um, so the New Mexico newborn screening program does have drying racks that are available. So if you don't have a drying rack and you would like one, then just reach out to Teresa or Carla, and they will hook you up with one, um, which is great. So they're super handy, especially if you're a bigger facility and you're drying multiple specimens at the same time. So yes, thank you for that. We have a couple minutes left, so I just wanted to kind of pick on Laura, our microbiologist in the lab. If you have a 30-second elevator pitch for specimen collection, any tips that you want to give people that maybe we haven't heard, or just to reinforce something that we've already talked about. And please, can everybody mute themselves if they're not talking? It looks like we have some extra noise.
I'm going to talk over the extra noise. Uh, this training is really great. I think that you've covered everything, but yeah, just to echo some of the really important things to the lab. Not taping, stapling, or paper clipping anything to your specimen. I think it's important that you know that one of the very first things we do is we separate that thin paper piece from the filter paper, and they go in completely separate directions. I think that's really important. And also, yeah, just single layer of application. Do not apply them on top of each other. It is the most common type of unsatisfactory for any program. So those 2 points.
Excellent, thank you. Sarah, do you have any advice or words of wisdom or anything you'd like to add?
And when it comes to filling out the parents' information, I know there was a question earlier about adoption or a surrogate. We want the parent that's taking baby home and who's going to be caring for the baby. So in the case of surrogacy, we're not really worried about birth mom. We're worried about who's taking baby home. Um, and there's a couple more questions here if you can see them in the chat. Where's a good place for a specimen label after it dries? I think if you're talking about like the hospital sticker that has the medical record number, date of birth, baby's clear spelling of name, we do like those stickers usually on the back side of the slip that you fill out. It definitely helps with our data entry team for clarity on spelling and, like I said, date of birth, the medical record. Sometimes the data collection is on there also. Of all of the newborn screens we send you guys, how many do you discard?
So we don't discard specimens. What we will do is, we'll do the best with what we have. Meaning if it's If there's not enough blood to run all of the screens, then we're going to run our time critical screens so we can at least get some data on the baby. If it's uneven saturation, well, we'll look for spaces where maybe there wasn't layering of blood or places where the blood did saturate through. Just to at least get some results, but then the results aren't necessarily valid and reliable because it wasn't a good specimen. But we don't throw specimens away. The unsatisfactory rate for New Mexico for last year was 11.3%. So 11.3% of all first specimens sent to the State Public Health Lab in Oregon were determined to be unsatisfactory, and a repeat collection was needed. And like Laura said, most of the unsatisfactory specimens are due to uneven saturation, and that is typically because people are putting multiple drops of blood into each circle and layering it. So I hope that answers your question. Carla or Teresa, did you guys have anything to add?
This is Carla. The only thing I wanted to add is we are planning on putting our newborn screening test refusal form on our website. If you do have a parent that does not want the screen done, you'll need to review the form with the parent, have them sign, send a copy to us, give a copy to the parent, and put the original in the baby's chart.
Excellent. Yeah, and hopefully that is not happening very often. I mean, we see it in Oregon as well. It is important to talk with the families about what their concerns are, why they're declining the test, and then, provide as much information and education as you possibly can. All right, I don't see any more questions in the chat.
There is one more here
Okay.
about if we write the infant info in the card, are we allowed to cross it? I'm assuming cross it out and initial and date it? Or do we need to do our due diligence to try to make no mistakes?
Great question. Ideally, you're filling out the card as accurately as possible. If the date or time of collection, was wrong, you can put one line through there and write the correct collection date. Sarah, do you have any other thoughts on that?
I would say, try to make it as clear as possible. We have data entry people that they type in what they see. If you have a card completely filled out for a baby and you decide to use it on a different baby, that's confusing. Please don't do that, especially if you're having to cross out every single field and write over it. I would say just get a new card. And oftentimes if families are losing their cards, misplacing, if we do repeats, we send cards from the lab to providers when needed to be able to recollect on somebody.
Can I chime in also? This is Laura.
Of course.
And from the lab perspective, consistency is nice. So if you were to send in a 0 kit as a replacement for an unsatisfactory first collection or something, the lab actually manually goes over and looks at the information you've written down to try and determine what kit was used on the first, so we know if we've already seen a specimen for this baby. So if their information has changed completely, that makes our life harder. So consistency is nice if you can do that. And also if you have crossed out a bunch of information, like say it's a legitimate first collection and you've crossed out a bunch of information, that makes that specimen suspicious to us. So we will still take that over to a computer and try and figure out if we've seen this baby in our system before. So from the lab perspective, that's what a bunch of crossouts does. It throws a wrench into our flow.
Yep, for sure. who do we need to contact if a parent needs a new card? So they are going to be reaching out to our lab, and we will provide a card.
Yes, I believe Carla could correct me on this, that there's local public health clinics throughout New Mexico that have supplies of spare cards. Those might get to you faster, whether they're mailing them to you or the parent is picking one up. We can always mail cards. We're here in Oregon.
Sure.
And
so yeah.
they can always call either me or Teresa. This is Carla. Just contact one of us and we can get a card to a parent as well.
Great.
But we do have them in the local public health offices.
And when a first screen comes in and it's unsat or unsatisfactory for any reason, we are reaching out to the primary care provider, asking them to recollect as soon as possible instead of waiting for that 2-week visit. If they use part 2 of the card mom was sent home with, we here at the lab and follow up kind of track as those come in and we see that it was collected early, and we will mail you a replacement card that should be used for that routine 2-week collection. So if the primary care provider is not getting those, they could certainly give us a call.
Okay, we're running out of time, so we have 2 questions in the chat I'm going to answer, and then we are going to hand it over to Suzanne. So if we transfer a baby to another facility, we normally send the card we have started to fill out with the baby. Is that okay with the barcode sticker that is meant for our facility? Cross out the barcode sticker and write in who the accepting facility is. That would be awesome, and that will keep our data clean, and we'll know who to reach out to if we need to. So thank you. That's a really good question. And was that the last one? I think so. Okay, thank you guys for tuning in to the first half of our presentation. I'm going to go ahead and pass it off to Suzanne, and she is going to talk about the hearing screening program in New Mexico. So thank you very much.